Good afternoon. Welcome to today's Wisconsin Health News virtual event on what's next for at-home care in Wisconsin. My name is Tim Stum. I am the editor of Wisconsin Health News. Thank you all for tuning in today. We have a great panel with us. I am thrilled to introduce Jessica Edsmiger, Operations Manager for Mayo Clinic Health System's Advanced Care at Home program, Sal Braico, CEO of Pivotal Health, Todd Costello, Executive Director of Community Living Alliance, Dr. Brian Horniman, Interim Executive Vice President of Care Delivery for Marshfield Clinic Health System, and Kevin Moore, CEO of United Healthcare Community Plan of Wisconsin. Before we get started, I want to make sure we thank our generous sponsors of the Wisconsin Health News virtual series. These important discussions would not be possible without their support. So a huge thank you to Advocate Aurora Health, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Gunderson Health System, Hush Blackwell, and Quartz. Wisconsin Health News is an online nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial, which you can do at our website at wisconsinhealthnews.com. And I want to give an extra thanks today to Anthem Blue Cross and Blue Shield of Wisconsin, today's featured sponsor. We are very grateful for all of their very generous and continued support. And here to say a few words is Dr. Julie Mitchell.
Yeah, thank you, Tim, for hosting this event, and thank you to all our panel participants for sharing their insights on the care at home trend. I'm Anthem Wisconsin's Chief Medical Officer and a practicing physician, and I'm particularly excited for today's topic because it's central to our goal of expanding care options, overcoming social barriers to health, reducing cost, and most importantly, driving better health outcomes at the individual and population level. Anthem is committed to expanding options for care at home through virtual care, digital tools for management of chronic conditions, at-home nursing and urgent care, post-hospitalization care, and at-home hospital care. When done right, at-home care, these tools can be more convenient for the patient. We've all experienced technological advances in the telehealth boom, and at-home care has already become a high-quality part of the care continuum. That, of course, includes brick and mortar care. I'd like to highlight three of Anthem's many successful initiatives in the care home space. First, Anthem Commercial does cover virtual visits, even as the pandemic protections are ending. And here I'm referring to planned appointments between patients and their primary care specialty providers. Depending on patients' access to transportation or their needs to be at work or be at home as a caregiver to kids or elders, patients may prefer to use telehealth or connect with their provider team virtually. Additionally, Anthem Commercial offers quick access to virtual visits via our telehealth platform, which is called Live Health Online. These visits may address urgent care issues like cold symptoms or bladder infection, or they may be longitudinal behavioral health therapy appointments, or anything in between. Second, Anthem Commercial has contracted with several mobile providers that often offer urgent or non-life-threatening emergent care in the home. These providers can come into the patient's home to evaluate concerns like fever, asthma flare, or head injury. More than a virtual care option, these providers can assess patients with a physical exam, perform laboratory testing, checking for things like infection, diabetes, or anemia, and then manage the condition with medication or respiratory services right in the home. Third, Anthem has a hospital and home program. Hospital and home is a way for selected patients who are sick enough to need hospital care to get those services safely and effectively right in their home. Of note, several Wisconsin providers have been leaders in the national hospital and home movement, and Anthem has been happy to partner with them. And last, if I'm talking about care at home solutions, I have to mention Carelon, which is Anthem's health services partner. Carelon has made at-home care a top priority, working particularly hard on developing best-in-class options for patients who need care at home after hospitalization, for palliative care, for home dialysis, and for infusions of specialty medications. For all these reasons, Anthem is proud to sponsor today's Wisconsin Health News panel on at-home care from hospitals to living rooms.
Excellent. Thank you so much, Dr. Mitchell. And thanks again to you and Anthem for all of the generous and continued support. So I'm excited about today's discussion and learning more about the future of at-home care. In Wisconsin, buoyed by the pandemic and technological advancements, providers are increasingly delivering care in homes. At its best, the at-home care movement promises to bolster access, increase patient satisfaction, and lower costs. But as care shifts from the hospital to the living room, hurdles remain, including safety concerns, outdated policies, and questions over whether economic projections will come to fruition. Meanwhile, the digital solutions fueling at-home care can be a barrier for patients, some patients that may benefit the most. So we're hoping to tackle these questions and more. We have about an hour to do it, so I am going to dive right into the questions. And I want to start, at-home care is a pretty broad term. It includes hospital at home level care, like what Marshfield and Mayo is providing, but also home health and other levels of services. So I thought we could start by having each organization just kind of briefly discuss the types of at-home care that they provide. And Jessica, let's start with you. Mayo Clinic somewhat recently launched its advanced care at home program. Can you talk a little bit about, when you launched this, why you did, and what you offer?
Sure. Yeah. Thanks for the question. So Advanced Care at Home in Northwest Wisconsin launched its program in August of 2020. Our command center is actually located in Mayo, Florida, which launched July of 2020. So shortly thereafter, we had our program up and running. And really the goal of the program was to provide acute level hospital care at home, being managed by our command center located in Florida, which has a team of MDs, APPs, RNs. Our patients in the home have tech kits that are set up and they virtually connect with this team multiple times a day. And then we have technology that is installed in the home, biometrics, vitals that are uploaded, constantly monitoring. And then our easy access button allows the patients to connect with their nurse or their physician just with a touch of a button. And really, we saw this as being the future of healthcare. And we do have a home health agency, hospice agency, palliative care agency, all providing home in the care or care in the home. And this was just really the next step in being able to provide care in the home and really where patients want to be seen. So we have a supplier network that helps us deliver that care, whether it's inpatient nursing going into the home, couriers delivering medications, labs being done in the home, x-rays, really everything that you can get in the hospital is provided by our supplier network going into the home.
Thank you, Jessica. And can you talk just a little bit about how this hospital at home level care differs from that home health care that you had been, providing previously and still are providing?
Sure. Yeah. So for home health, it's those patients that are homebound with a skilled level of care that's needed. Our advanced care at home program really is patients that have met the inpatient criteria. We have two pathways into our advanced care at home program, and that is either through the ED. They come in for emergency department visit and they are going to be admitted to the hospital. Our team will intervene and take the patient right from the ED home, or it is our reduced length of stay where a patient is already inpatient, maybe for a day or two, and they come home with our team and continue their hospitalization at home.
And are there, for the hospital at home care, are there certain conditions that this works best for? And like, what are some limitations? What are some conditions that this maybe doesn't work as well for?
Yeah, so we do have a social stability screen that our acquisition nurse or case management team does. And they're really looking at, is this patient going to be safe at home? What kind of support do they have in the home? And then things just like, do they have running water? Do they have electricity? Those kind of essentials. And then we have a clinical screen that a physician or APP does with the patient. And we do have certain diagnoses that we have on our kind of we call a fast pass list. So if an ED provider or our hospital medicine team see these diagnoses, they're kind of the first patients that get pushed to our advanced care at home program. We started out during the pandemic, and COVID actually was one of those diagnoses that right away we were taking patients home from the hospital and caring for them at home. We see quite a few of patients who just need antibiotic treatment course at home, so cellulitis, septicemia. And then we have definitely some new use cases that we continue to explore and have done things in Florida and Arizona and here with like vascular surgery, orthopedic surgery. So continuing to expand that list all the time, and it's really exciting.
And what are some things that, it's kind of some specific things that it's just maybe not working as well for right now?
Yeah, I think one of the challenges for us in kind of rural Wisconsin is I think every hospital faces the staffing shortages. So we have been fortunate in our program here to be able to hire nurses, Mayo nurses into the program to provide those in-person visits. And we have other home health agencies in our area, but definitely we see that kind of just the staffing shortages, whether it's a courier service or phlebotomy, those kind of things that it feels that those can be barriers to a more rural, not so populated area.
Great. Dr. Horniman, it's my understanding that Marshfield contracts with a couple of national organizations for hospital at home level care and house call type care. Can you talk a little bit about the care that you offer at Marshfield and how that decision was reached to contract with Dispatch and Contessa for some of these services?
Yeah, you bet. So for us, providing at-home care has been a really important part of how we provide care as the health system, and been doing that for a number of years. And we do have a partner with Contessa. They help with our home recovery care program. That's our hospital at home program. It's a joint venture between the two organizations, and we provide that acute level care that Jessica was speaking about. We offer also a completion of hospital at home model, and that's come in really handy when the hospital has been full, when we're at kind of peak census, folks that are just maybe needing another day or two in the hospital, not quite ready to go home and be completely discharged, but have a few extra needs. They can complete their hospitalization at home with the help of the program through a lot of the same mechanism Jessica was mentioning. We also have a post-acute phase. So we have a sniff version of this. So if patient needs some nursing home level services after discharge, we'll provide that in the home using that same chassis that we did for providing the acute care. So provide that whole spectrum, and that's through our home recovery program. And then, as you mentioned, Tim, we do have a partner in Dispatch Health, and that's more of the traditional house call sort of model where someone will come to your home. So you'll call into our nurse line, or you can call into Dispatch Health, and we will have an APC come to your home, and they can provide a whole level of diagnosis and treatment. They have the ability to do a spectrum of labs, some moderately complex labs. They can do some chemistries, they can do lactate, they can do an INR. They're able to do they can do EKG and X-ray services at home, and then provide instructions and ongoing care. And really that's a avoidance model where we're trying to have people stay in their homes, get their treatment there, and not have to come to our emergency departments and seek care there. And then we've got more of our traditional telehealth models that we provide from the clinic settings, as well as through a program called Care My Way. And Care My Way has been something we've had for quite some time, where we've had nurse practitioners via telehealth working with our nurse line, answer questions, do some basic diagnosis, and do recommendations, but oftentimes can provide treatment right there without having the patient going to urgent care or ER.
Where do you see some of the greatest potential for at-home care?
Yeah, so I think the potential is growth. So we have also been growing the number of diagnoses that have been working well with our hospital at home programs. So some of those cellulitis, UTI, pneumonia, heart failure sort of diagnoses we've had for a number of years, those that have responded well because you can treat those via protocol. We've also expanded to a number of other conditions, and actually about 40% of what we treat now is in another category. So a wide variety of other conditions that we've been able to have our physicians screen the patients, determine if this condition can be treated at home. And if it's something that can be safely taken care of at home, the patient has sufficient stability, then though that diagnosis didn't fall into one of those 5 or 6 previously identified, they've gotten good results with expanding that, knowing what the patient resources are, knowing that the resources of the system are, and that backup that if the patient needs more resources, we can get that to them.
Well, what are some conditions that, this isn't working as well for right now? I mean, what are some of the limitations of this?
Yeah, some of the from a condition level. So it's that kind of the real high level care that you would need to give. So patients that would need to be on telemetry or ICU care, of course, that doesn't work as well. Also, that those that maybe have significant mobility needs. So you need to have a patient that's able to have a good social support at home, be able to have sufficient mobility to have their activities of daily living addressed within the home. So those are some of the limitations. Let's see, Tim, you might be on.
Yep, I am. Todd, sorry about that. Todd, tell us more about Community Living Alliance and the type of care you offer. This is not a new thing. I know you guys have been doing this for a while. Tell us a little bit about what you guys do.
And muted there.
Yeah.
Community Living Alliance has actually been around for about 3 decades. Where we were founded by people with disabilities, and we provide in-home care for all ages of individuals with disabilities as well as older adults. And it's sort of the basic services that we all take for granted: bathing, showering, the ADLs. We provide chore services, and we also provide, we have a behavioral health arm as well, providing in-home counseling and care coordination. But the personal care piece is really the first rung within the healthcare continuum, and it's the basic things that people need to maintain their independence. We support many individuals who wish to work or volunteer within the community, and so it really is essential to really quality of life and helping people have a meaningful day.
Great, thank you. Sal, what about you? Can you tell us about a little more about Pivotal Health and what you do and why you launched this company?
Sure, Tim, thank you. So yeah, we started Pivotal Health back in 2020 with the specific goals of making healthcare easier for both the consumer and for our providers. And the way that we are doing that is combining the old with the new. So, I mean, the old is the clinician house call, which up until I think it was like 1960 or something, the clinician house call was the dominant way that most people got healthcare. And, that's where the physician would come out to your home or to your farm or something and provide care. And so we are combining that, having Pivotal Health providers come out to your home or to your office or to the soccer field. We're combining that with our tech platform, where we've automated everything around the visit, from the triage, the scheduling, the payments, and then on the provider side, automated a great deal of their charting process so that our providers can really focus on the patient. And so we are doing this for all ages, infants to the elderly. We're doing it for urgent care and for primary care and for basically everything around that. And, we can do anything in your home that can be done in an urgent care clinic or in a doctor's office. Point of care tests for COVID, flu, strep, mono. We repair lacerations, we do IVs. We even do x-rays too. So full suite of capabilities.
And how does this, it sounds like you are offering a lot of services, but how does this differ from like hospital and home level care?
Yeah, so people are typically using us for urgent care and for primary care needs. So this is, dealing with a lot of upper respiratory infections or urinary tract infections or rashes or sprains, lacerations, things like that. And then on the primary care side, it's a lot of the wellness stuff. So we are not typically taking care of a patient that got released from the hospital and providing that kind of care. It's more like I said, on the urgent care and the primary care side.
Great, thank you, Sal. Kevin, in what ways is United Healthcare involved in at-home care? What are some of the things that you all are doing?
Yeah, thanks, Tim. So it's great to be part of the panel because I think you can hear the broad swath of what providers are doing in this space. For us at United Healthcare, we're actually continuing to get further upstream to really augment the great work that goes on at the provider level. And a couple of things that we just have deployed recently in Wisconsin, first and foremost, for our dual special needs individuals, both Medicare, Medicaid, very vulnerable population, something we're calling United Healthcare at Home. Not a very original name, obviously, given the topic. But for us, this is really about providing an ongoing proactive engagement through navigation, where every single one of our dual special needs members has somebody, a point of contact within the health plan. And that point of contact is really designed to say, look, where are you this quarter on your clinical needs? Where are you on your social determinant of health screens? Are there things that are popping up so that we can get ahead of that as a team, keeping in mind that this is not a replacement for a PCP. This is not a replacement for their specialist. It's really designed to be a kind of an upstream early detection capability. What's also great about United Healthcare at Home, though, is it built into that is a stratification capability, so that as a member starts to become sicker, maybe has increased needs for social services, we can actually layer on additional in-home supports, whether it be an RN, an advanced practice clinician, all the way up to an MD in the home, in order to provide that stability and engagement in the community, which, as we all are talking about, you do get the best outcomes when people are in their homes in terms of both immediately and then also the long-term benefits. We have a program called House Calls, a very similar program there where it's much more clinical. A clinician comes into the home, they can do everything from screenings for SDOH to doing labs. All of that data then gets reported out back to the member as well as to the PCP. So again, we want to continue to provide information so that when there is a PCP visit, that they're getting that information not only about what's going on in the four walls of the clinic, but what also is going on in the home. But I'd also be remiss to talk about, those are kind of the big programs. We also have programs, and we're very excited about a partnership we've had since 2015 with the Milwaukee Fire Department, where we've actually contracted with the paramedics in Milwaukee to do basically two different approaches. One of them is really about preventing people from going back in the emergency room and preventing readmissions. And the second part is really identifying super utilizers, high utilizers as well. And so the paramedics are a trusted entity. They come into the people's home, they're able to provide immediate services, but they're also building trust. And I think one of the things for us that we see really important about this model of care, if we're going to think about disparities, if we're thinking about inequities in healthcare, there is something about in-home care that is allowing people to build trust. It's building trust, whether it be from us at United Healthcare as a healthcare insurer on the Medicaid or the dual special needs side, or even the providers that you're seeing here. Each time is another opportunity for us to show, look, we're bringing the care to you. We want to see what's going on, not just about what's on a chart, but what's going on in your life, what's going on around you, because I think that allows us to get a better 360 view, knowing that, as the old adage says, 80% of healthcare comes outside the four walls of a clinic. That's really, I think, the benefit of this modality of treatment and where the innovation is moving forward.
And Kevin, let's stick with you for a minute. So some of these services, I know you've been a part of for a little while. Some are newer. What do you think is driving this kind of overall change, kind of increased interest in some of this at-home services?
Well, in 2020, we had this thing called the pandemic, which it wasn't even a game changer, right? It was a paradigm shift. It went from telehealth was a concept that was talked about and debated. It was now a necessity. If clinicians now, we needed to find a new way to connect members and patients to clinicians. And so you saw this acceleration of policy and of product, if you will, because of the pandemic. What's evolved out of that, though, I think is, and whether it be a patient or a member, you're starting to get people now accustomed to this. They actually are starting to ask more questions. They're getting more engaged in their healthcare. It's created a new level of expectation, where now, wait a minute, I used to do this over the phone. What do you mean I have to come back in? Or I really like the fact that you're coming into my home now. Yes, we had masks on, we followed the COVID protocols, but are you going to come back? I think that's really, while we can say it tongue in cheek, it was a defining moment in terms of how we deliver healthcare, and it was out of necessity. There was no, we didn't have the luxury, unfortunately, of saying, well, yeah, but let's hold off on that, because we needed to, as carriers and as health insurers and as providers, we needed to make that connection. So it's here. I think right now it's a big question moving forward is just where do we sit in all of this? And the biggest drivers of that are going to be the patients and are going to be the members and what their expectations of healthcare is moving forward. And that's even before I layer in the generational changes that have evolved, where millennials and Gen Zs, I think I always get which one I'm not in that generation, but their expectation of how they get healthcare is dramatically different than the people on this panel or our parents or grandparents. And so being responsive to that, this type of modality is going to be here for the foreseeable future.
And how, and you're kind of just addressed it, but could you just expound a little more? How are your members responding? What do you think? It's going to vary a lot, by member, but what are going to be some of those expectations going forward? And how, have they responded overall?
Well, we gauge a lot based off of just NPS, what our members say when our different services are engaged, and they really like the personal attention that comes from, whether it be a house calls visit or the fact that they have a navigator that they can pick up the phone and talk to, who actually knows a little bit more about their actual case. And then also the ability for us to be able to leverage that data to connect to our provider partners, right? So that data it's not discrete to us, so that when a member is going through that continuum, it's kind of like a duck on water, right? The providers, the carriers, SDOH, ideally SDOH, community-based providers, we're all swimming frantically so that there's that smooth process. And that's the ideal goal. But I think that this modality is going to be, the reality is that the members are liking it more because it's bringing it to them. And that's what we're seeing through our performance reviews from just even the verbatims. We like you to come in. I will also say this. I think it's also changing the dynamic, because a lot of folks that, and I think Dr. Herman, you talked previously about people that may not be engaged, or how do we get people engaged in the process. This is a really great way of showing that we can engage. We want to engage, but you start small and you work your way back up, which is a different approach than somebody that needs to get into a doctor's office today. So it's a long game versus a short game.
Thank you. Todd, in kind of what ways, other ways kind of in general overall is at-home care changing? And what do you think is driving that change?
Well, I think that obviously, I think the pandemic really allowed us to create some freedoms that probably would have taken decades to create. We were all forced to shut down and to look at how we could benefit from technology. It's a known fact that people want to remain home as long as they possibly can. It's cost effective, but I also think there's great opportunities to look at the larger healthcare system and looking at how we can coordinate, returning people back to the community where partnerships could be formed. For example, we do work with MCOs to help prevent readmission, and it's been very successful. We can do a home safety assessment. We can make sure that they have food in their refrigerator, or that the refrigerator is even working. And I think that, sometimes we have our best laid discharge plans, but sometimes they fall apart. And when you have the eyes and the ears of the community actually in the home, I think it's really powerful, and there's great opportunities, I think, for early detection and prevention of ER visits, hospitalizations, and I think that the future really brings a lot of opportunities to lock arms and look at the whole system. I think there's some barriers because funding and silos, need to come down for that to happen. But as we look at some of the efficiencies, we know it's cost effective, it's proven to be safe, and it's what people want. I think there is a growing trend that people do want to have more in-home services, and there's even more funding through the federal and state through some of the ARPA grants that are really moving towards home and community-based services. And there's a lot of community-based providers that could really partner with hospitals and nursing homes and other facility-based service settings to really work on some common shared goals and outcomes that would benefit person-centered care.
So Todd, COVID-19 has accelerated a lot of this forward. What does it mean now that the public health emergencies are ending? I mean, what does it specifically mean for home care and telehealth?
I think we benefited from the emergency rule during the pandemic, where we could provide, personal care is a high touch service, obviously. But there are administrative aspects of that care, for example, supervisory visits that we were allowed to do during the pandemic that unfortunately went away May 11th with the ending of the emergency rule. And we have a direct care workforce shortage, but we also are seeing a significant RN shortage. And so when you look at some of our rural communities and the efficiencies that we were able to do more in-home supervisory visits through telehealth than traveling. And with the shortage of RNs, it's just becoming almost necessary to go back to reconsider that, because just the loss of time and just not having the staffing. And again, it proved to be safe. It was convenient for folks, and both clients had it was really something that they valued.
Dr. Horniman, shifting to you, as we look at maybe some of the limitations and barriers, is there any concern that care in someone's home isn't as safe as it is in a hospital, where you have all the equipment and supplies you need to address an array of conditions and a slew of providers available if complications arise?
Yeah, we've been able to see over time really a good track record of safety, not just with this program, but with other programs in general. And the safety profiles of these programs have been great. In fact, if you look at our complication rate in 2022, there's actually zero complications in our program for things like unexpected mortality, wounds, infections that would be inquired in a hospital. So we've seen actually really nice safety profile. Some of that is the screening that goes up front. So you want to have the patients appropriately selected for the program, those that have conditions that can be safely taken care of and monitored within the home. But overall, the safety track record of the programs really has been excellent.
What about insurance coverage? Well, what does insurance coverage look like for at-home care, and how much of a barrier at this point is that?
So that's been a journey. I think that's still a journey for these programs, and things are continuing to develop over time. And having a really well-defined payer structure has still been elusive. So we are seeing that grow. There are still some limitations with private payers. We've had the ability with having our health plan to be able to leverage that. So those that are part of our security health plan have been able to participate in the program since early on. So we've been able to share that program development with our health plan, and then coordinate the payment to the program to allow it to happen at home. There's been an extension. There was an omnibus bill that was in December of 2022 that it's going to extend hospital at home coverage from CMS through 2023. So that also provides us a little bit more time to develop some more of those strategies. But that is an important thing going forward. Having a really defined payer structure going forward is going to allow those programs to continue to expand.
What are some other barriers or challenges preventing at-home care from progressing more?
Yeah, and actually one of the ones that we ran into within the last couple of weeks is the one that Jessica mentioned was the staffing. So staffing does matter. We work with a number of home health agencies, and home health agencies are struggling to staff. So in our rural networks, there is not always someone there that can go to the home and provide the care and the time they need, and then the patient does not, although would be otherwise eligible for the program isn't able to support that needed time, and then the patient is taken care of traditionally in the hospital. Distance is another one that matters. So we do have a radius around our facilities that are providing hospital at home. So we have a number of our hospitals in the health system where we support hospital at home. But there is defined radius because there is some courier services that go back and forth. There is that home presence within the home by either a home health nurse or APC. And so there is also the rurality is an issue that limits some of the care we can provide.
What about technology? How much of a barrier it's helping progress this, but in what ways, if at all, is it a barrier? I mean, both Wi-Fi access, but also patients' ability to utilize technology, for things maybe like remote patient monitoring or things like that.
Yeah, it matters. And you do have to have adequate Wi-Fi access at home. So broadband access in rural Wisconsin is improving. It's better than it used to be, but it's still not perfect. And that needs to be in place to have some of the monitoring, have those interactions with providers and nurses that are done remotely. And you have to have sufficient bandwidth for that to occur. But yeah, overall, it is improving over time, but it's still one of the things that we have to check off when someone's going to enter the program is, do you have adequate internet access?
Jessica, is there concern that this, could be seen as a health equity issue, that, hospital at home care, at this point only works for certain patients that have the resources to make it work?
Yeah, that's a really good question. I want to say no, but obviously, yeah. I mean, that is a concern that, we're trying to, as Mayo Clinic Health System and Mayo Clinic Florida, work through that. And, things like Medicaid, we're not able to take Medicaid patients onto the program and get paid. So we do have strong advocacy groups and contracting payer relations, all of those kind of things. We do, with the internet piece, we do try different technology in the home with using external antennas, bringing in cellular connectivity, those kind of things to increase the reliability, and doing those tech installs ahead of time to make sure before we bring the patient home. But yeah, I think there's still work to be done in that arena, and hopefully we'll see progress in the near future.
Jessica, what other types of barriers or challenges do you think still exist for at-home care?
Gosh, I feel like we've mentioned quite a few of the ones that come to the top of my mind. But I think sometimes there's still physician buy-in, patient buy-in, in supporting the model. I think we've seen some really good success with, we've done a pilot where our hospital medicine providers are keeping the patients on their panel that we take home with ACH, and they're getting to experience some of that virtual care firsthand. And that has really helped with them having that buy-in for the program and talking to their patients up front when they come into the hospital, that we have this really great program. This is how we care for your kind of diagnoses. The treatment can be provided at home. So I think we're making good progress, but that is still something that is there, and will take culture change to move that forward.
Great. Sal, you're a relatively new company. What are some of the barriers and challenges that you're running into in continuing to expand your services?
I'd say that our biggest challenge has just been trying to convince people that we're real, You know, I mean, when I, you know, talk with people, I say, hey, so our provider comes to you, like the provider comes to me, to my house. I said, yeah, they come to your house or to your office or, you know, wherever. And I say, and you pick the time. They say, wait, I can pick the time that they come? I said, yeah, you pick whatever time that, you know, that you want them to come. And then I say, and this costs less. And they say, wait a second. How do you send a provider to me at a time that I pick and it costs, and it overall costs less? I say, because we created this platform specifically for this purpose. We don't have legacy clinics and legacy admin that we're dealing with. And about 90% of our patients use insurance. United is our biggest payer here, with Anthem probably number 2. But it's just been us just trying to convince people that, yeah, it is possible to make healthcare easier. It is possible to deliver high quality, affordable healthcare right to you. And so that's really been our biggest challenge.
Kevin, what impact do you think that all this can have on cost?
It's a really great question. I think that Sal brought up a good point, that we're always looking at the ROI for all of these. I mean, I think as a culture, we're always looking at ROI. And I definitely think that we're seeing if the populations that are being engaged in these types of interventions, if they're aligned correctly, I do think you get some really great positive outcomes out of it from a financial perspective. But I also think it's bigger than that. ROI tends to be a financial calculation. I think we're looking at it also through this lens of what's kind of that social ROI that comes along with it. Thinking about the Medicaid population in particular, you know, how can we use healthcare at home or in the home as a means of mitigating one of the biggest barriers to healthcare, which is access to transportation. You know, despite the fact that Medicaid provides non-emergency medical transportation, we still know that that's a challenge moving forward. So I do think that there's an opportunity for cost. I think it's in terms of kind of where we are in the continuum, we're still trying to figure some of this stuff out. So I think whether it be from an innovative startup side of things or from a legacy perspective, I think we're all trying to figure out what is the best kind of math about who is the best, both from a safety perspective, but also understanding that it's a continuum, right? As I kind of outlined, we're looking at it through not just post-discharge, right? Like that's obviously a cohort that we really want to wrap around in the community services, but how do we get even further and further upstream? Because the challenge sometimes is it's difficult to put an ROI on prevention until you realize that there is an ROI about prevention and about engagement of members further up. So I think it's promising. We've seen some promising ROIs as it relates to our paramedic program in Milwaukee. We do see decreases almost across the board in terms of reutilization, in terms of overall costs going down. But again, it's for a focused population. And so I think as we learn, we evolve, we adapt, and then we figure out what the best situation is. And I think the best outcome is when you have payers and providers, community-based organizations and advocates really kind of pulling together in the same way and identifying things like this. What are those barriers? And how can we at least pull all the horses in the same direction? Because ultimately that's going to give us the best population health outcomes, whether you're looking at that through a financial perspective or from an outcomes perspective, which I think we're all interested in.
So Kevin, I know you can't speak specifically to the commercial side. You work in Medicaid, but continued coverage, Medicare coverage, commercial coverage is such a, and Medicaid coverage is such a big part of this discussion when it comes to this movement of more care being delivered at home. Do you think just kind of generally, it's going to take a little time for commercial insurers to kind of be all in on some of this? Is it, what are your thoughts?
I think that the point Dr. Herman brought up is it is evolving. It's a conversation that payers and providers are having all the time, thinking about the new offerings and also thinking about the capacity issue. While we may look at it through a clinical lens of I have X number of bed space and I have Y number of patients coming through the door, that same equation happens on the commercial payers, on whether it be commercial, Medicare, Medicaid. The same issue happens with us when we're looking at access or network adequacy. So I do think that there's a partnership on evolving it to making sure that you find those right pathways. Tim, I'm a Medicaid guy, so I will go back to, I do think that you know, Medicaid tends to be in certain instances, and I think CMS did this through the pandemic, they can be a huge catalyst for change. Thinking about what are the best practices and how do you bolt them into either a fee-for-service structure, a Medicaid managed care structure, then because that tends to be the layering that happens. Then all of a sudden you get a little bit from Medicare and you start to build momentum that maybe moves into some of these other payer products. But I think the momentum is there. I think you're hearing a lot of different ideas and a lot of different, and the commonality that I would say is no matter who you're talking to on this panel, the patient or the member is still the same. We still, as team members around that patient, around that member, we're trying to make sure that they're getting the best health outcomes we can. And it's kind of imperative of us to keep this dialogue going. So that's why it's a great, I don't know if we can say the pandemic's over. At some point, we'll have to be able to say those words. But as we emerge from the pandemic, I do think there's an immense amount of momentum for these types of partnerships and creative, innovative ways of delivering care into the community.
So what about care coordination? You know, as patients are maybe now getting care in different ways, you know, from different providers. And Sal, we'll go to you on this one. Is there a concern that you know, maybe the care being provided isn't coordinated with, you know, the care they're receiving from their primary care doctor or their health system?
Well, I mean, when we see patients, we, you know, right after the visit, we electronically send the CCDA, the visit notes, to the patient's PCP, if they want us to. Okay, so we, you know, leave it on the patient to, you know, tell us what they want, and so, you know, that's how we've been able to kind of keep the primary care providers in the loop. You know, I think. Over the last 20 years that I've seen, the interoperability between EMRs has gotten better. It's not where it needs to be, but it is definitely leaps and bounds better than it was years ago. So our providers are able to see all of the patients' previous visits from any Epic organization. They see those before that they even, you know, get there. We've got a prescription feed from one of the national you know, providers of that. So we actually see all of the patient's medications before we get there, and so, you know, that's how we're able to kind of maintain that continuity. But, you know, we also do expect that patients need to tell us. If they don't tell us, then there's really not a lot that we can do.
Todd, you at the beginning of the program brought up, you know, a challenge, a barrier is that some of this care, specifically done by personal care workers, can be siloed and you know, maybe isn't as coordinated. I mean, what more do you think needs to be done to make sure that this care is more coordinated?
Well, I do think one of the common denominators with everyone is really looking at some of the challenges in serving dual eligibles. And obviously, I think they're an at-risk population, and primarily that's who we serve. And so looking at cost-effective ways of coordinating care, you know, for example, you know, we can support someone who's newly discharged from the hospital, and when we go into the home, they may need a hospital bed, but it isn't there, or other DME type things. And so being able to coordinate that and to work with hospitals and health plans to make sure that everyone has the best outcome. And again, just looking at an impact on rehospitalizations, I do feel that more coordinated effort could actually address that issue, and the cost savings from penalties, and also just looking at health and safety issues related to you know, people who necessarily have preventable hospitalizations. And so I do see future opportunities there, and looking at how we can break down some of the silos of funding. And you know, for example, we talked a little bit about commercial insurance, and there are Medicare products, Medicare Advantage programs where personal care is actually available to beneficiaries. And so we'd like to see, you know, more movement towards that as well. But I do think it's looking at breaking down some of the payment silos as well.
Great. Dr. Horman, what are your, sorry, someone, Dr. Horman, what are your thoughts? I mean, is there a concern that some of this care isn't being as coordinated as well as it could? And kind of what more can be done to make sure that this care is coordinated?
Yeah, the interoperability is not perfect. And yeah, it is a potential risk that the systems don't talk to each other. So we have to be pretty intentional about how we plan it out. And so you have to take steps like devising ways for these different platforms can have those providers can have read-only access to the health record, that sort of thing, be able to get the information they need to be able to take care of the patient in front of them. And then similarly, make sure that there's a path backwards, either through the provider or through the health record, that the information is getting back into the system so that the primary care provider and or whoever's going to be continuing that care gets that information. But it is manual at this point. There is opportunity for it to continue to be less of something where you have to pay attention to it. It'd be great if it was just something that occurred and there was that interoperability.
Great. So we are nearing the end, and I want to make sure we have enough time to have each of our panelists answer this kind of final question. We've talked a lot about what's driving, increased at-home care across the state. What are some of the barriers? But what's next? What's the future of at-home care? Jessica, we'll start with you. What do you think? What do you think at-home care is going to look like in the coming years? I mean, I think you're still on mute, Jessica. We still can't hear you. All right, Jessica, we'll come back to you. Dr. Horniman, now let's come back to you. What are your thoughts on that? I mean, what is at-home care going to look like in the coming years?
Yeah, I don't think it's going away. It's had a really great track record so far. We've seen more and more applications for it. We're exploring other areas where we can use it. There are opportunities like home-based primary care, home-based palliative care that are in front of us that we're looking into. So yeah, I see it continuing to grow and be part of how we provide care going forward.
Great. Sal, what do you think? What's next for at-home care? What's it going to look like in the coming years?
Well, I mean, more and more people are demanding this, right? They are demanding this convenience. And so I just see it taking off. I mean, our two biggest populations that are using this are millennial families and Gen Z. Right, those are the two biggest populations that we have. Like, they're so used to using their phones to order food or to order cars or to whatever. There is this demand for, hey, why isn't healthcare like this? And so, as those populations continue to get older and are using healthcare, and they have more children and things, the demand for this is just going to keep on going up and up. And that's what we're really focused on, is just trying to make this whole process as seamless as we possibly can.
Great. Todd, what are your thoughts? What's the future of at-home care?
Well, I do see great opportunities for collaboration as we move forward. I also think there needs to be a shift in how we educate healthcare providers. I think right now there is more of a disparity between facility-based settings versus community-based settings. So I think we need to see a shift there. I think as the population continues to age and people with disabilities are living longer, the whole workforce, I know we all touched on that, but we need to plant the seeds today. I mean, the workforce is inadequate today. And so as we look at future needs, I think we need to develop strategies to address that.
Thank you. Jessica, are you back? No. Well, Kevin, we're going to give you sorry, Jessica, Kevin, we'll give you the final word. What's the future of at-home care?
I agree with everything everybody said. I'll be a little bit aspirational though. I think it, you know, the ability for us to meet members, patients in their homes, being able to get, I mentioned this before, getting a more holistic view. I think there's a huge amount of promise about addressing disparities and inequities that right now, you know, just reading in some of the newspapers today about infant mortality in Milwaukee, been relatively stagnant over the course of the last few decades. We need to have this type of change, and it's going to happen by getting more data, but not necessarily a CPT code or something like that. It's finding this more of a social and community data that is going to help providers, payers, community-based organizations to really align better behind what is needed. So I'm actually very eager, and I think there's huge opportunity by just changing the way we're providing care, in addition to the fact that it's what the people want. And I think that's going to be probably even the bigger driver moving forward.
Excellent. Well, thank you, Kevin. Thank you all. This has been a great conversation. Really appreciative of all your time. Thank you to Anthem and all of our sponsors for their generous support to make conversations like this possible. And thanks to all of you for tuning in. We hope to see you next time. Thank you.